Social workers can encounter women with intellectual and developmental disabilities, or IDD, in many different settings. Our team is working on a project in which we are examining the experiences of women with IDD and parenthood. We spoke with women living with their families and women living independently or with partners, women interacting with social services, women working through child custody court cases, and women looking for jobs. Little is known about women with intellectual and developmental disabilities and their healthcare anecdotes during pregnancy. One part of our project involved interviewing women with IDD who had recently given birth to talk with them about their healthcare experiences during pregnancy. We heard both positive and negative narratives, but many stories centered around support systems. In this short video, we will review the findings collected from speaking with 16 women from across the country. We let women self-identify as having an IDD, including diagnoses of autism, Down syndrome, developmental disabilities, and other cognitive diagnoses. We reached out to agencies that work with adults with IDD to help with recruitment, and also contacted residential and recreational centers for help distributing our information to our clients. Most of the women we interviewed were around 26 years old, and many of them had not been planning on getting pregnant. Almost 1/3 of the women we spoke to us about their first pregnancies, though some interviewees had had more than 5 children previously. Some of the women had had their children removed in court cases. None of the 16 fathers were involved in the mother's pregnancies in some capacity, ranging from being in communication with the mother to accompanying her to appointments throughout the pregnancy. Only one woman we interviewed was married. Almost 1/2 of the pregnancies were labeled high risk by healthcare providers, which is not uncommon according to recent literature in this area. Previous research has also shown that women with IDD more often lack prenatal care, deliver early, and deliver babies with lower birth weights and lower APGAR scores than women without IDD. We asked women about their interactions with doctors, nurses, and other healthcare providers. 3 common themes arose surrounding provider interactions. The first was that providers did not explain information clearly, or give enough explanation when describing pregnancy or various tests or protocols. This ranged from prenatal advice to postnatal communication. The lack of information and explanation led to confusion and frustration for a lot of the women, which in turn negatively affected their pregnancy experiences. 12 of the women explicitly mentioned not receiving enough information throughout their healthcare visits. Here are some notable quotes. "They just kept telling me everything's okay. Don't worry about it. No, I'm getting text messages saying something different. They let us stay, but for the first 4 nights, they kept taking her out of the room, and they wouldn't give me an explanation. They would tell me if I ate and threw up to repeat those calories. Then another doctor would tell me no, those calories are those calories. That was confusing to me." The second theme we found was that many of the women felt like their providers weren't listening to them. Many women reported asking for help, but felt that their healthcare professionals neglected to answer their questions or take the extra time to explain more thoroughly about procedures and pregnancy advice. Here are some notable quotes. "I said I wanted to stop smoking, and she told me, well, it is bad for the baby. That is all. I was like, that is no help for me. Can you help me?" They were very rude. They disrespected me and they didn't listen to me about when I was pregnant. I told them that I didn't feel any movements. They just said it was fine. "I just felt disrespected because we told you no. I'm her mother, and if I had said yes, that's what goes." The third theme dealt with healthcare providers not giving patients enough choice in their own medical decisions. Patients described decisions often being made without their consent. Often, these decisions had to do with inducing birth or withholding information from the patient. The feeling of stolen agency caused extra stress, frustration, and distrust of providers. Not having enough choice in medical decisions has been corroborated in literature that has been written on this population as well. Here are some notable quotes. "I am more concerned about the fact that I either don't remember or was unclear on why I was being induced in the first place, because I am pretty sure they don't just induce you because you're asking to be induced. Where is it? Where is my other baby? If there was a twin, why did they not show me my baby? Why did they not tell me? I was afraid they were going to force me to do the breast group. They were trying to force me to do it." Some interviewees did mention positive experiences with their providers, but the negative provider interactions were more prevalent in our interviews. We also looked at both informal and formal support systems that many of the women interviewed relied on. Previous studies on parenting for adults with IDD have found that targeted interventions on parenting techniques can significantly help parents with IDD gain parenting skills and confidence. 5 different kinds of formal supports were mentioned, including residential care, mental health counselors, parenting programs, parenting books, and social workers. More than half of the women mentioned helpful social workers that supported them throughout their pregnancies. Here are some notable quotes. "She is the only person who can give us transportation. She either comes here and picks me and my daughter up or takes us. If one of us has an appointment, she will take us to the appointment. Like if we need rides to get places, just call or let them know in advance, and they'll bring us to our appointments." Formal supports and social workers in particular were really helpful for transportation to ease accessibility to healthcare. Many women also mentioned the helpfulness of social workers when planning during pregnancy. Social workers often aided in finding providers, teaching about healthy habits, and preparing for after the baby was born. Here are some notable quotes. "She made me take pictures of everything I ate. She put this app on my phone to help me because I had to walk a lot. I take pictures of what I eat and it tells me how far I am weekly. They help out. They have visits once a week. They come and meet with us and discuss housing stuff and ways they can help us. She comes every Tuesday at 11 and we weigh the baby, we get her height, and we get her head measurement to see how long she's growing. She was really nice too, and she was able to give me some advice about parenting. And we watched videos on pregnancy, and then it showed in the video what I should expect throughout my pregnancy with the baby. They made sure that I was capable of caring for him and everything, and they made sure I basically had everything that I needed." 15 of the 16 women spoke about the assistance of informal supports during and after their pregnancies. Informal supports included family members, church group members, neighbors, and friends. Informal support for transportation to and from appointments, as well as general accompaniment, was especially valued. The women also spoke about the comfort of the peer support perspective. Here are some notable quotes. "She had 2 children and she has cerebral palsy, but she was able to have 2 children, so she's been giving me good information. It was okay, but it was better if I had somebody with me. They won't judge me because they know how difficult it is for me, because I don't have anyone. His mother did help me to not be stressed out, so she kind of talked to me and tried to help me calm down, to keep calm." We wanted to separate the importance of the women's partners from other informal supports. As mentioned before, more than half of the women mentioned partner support. Partners help with practical issues, monetary involvement, encouraging healthy behaviors, and general help throughout their pregnancies. Here are some notable quotes. "I was throwing up and my husband was so concerned about me. Try to eat anything, even a little bit. He was involved because he ended up getting stuff for the babies, and also he ended up spending his money to get the cravings for me. Yes," he would say, "go out, go walk that way." Anything I needed or said I wanted, he would go get. "My boyfriend talked to me, and when I was going through my contractions, he said to try to think of something or sing something, or try to distract myself so I wouldn't be in that pain. So I sang a song and my boyfriend sang it with me." In general, the community surrounding these women helped them communicate with their doctors and feel empowered about their healthcare choices, increasing their capability to plan and prepare for parenthood. This study highlights the need for emphasis on both formal and informal supports by clinical care providers during pregnancy, childbirth, and postpartum to better pregnancy and parenting experiences for women with IDD. Future implications include the need to add curriculum competencies to clinical care education programs surrounding patient contact and communication for patients with IDD to improve their care quality and experiences. Policymakers and social workers should take into account the results of this study when working with parents with IDD and recognize the positive effects parental training can have on this population and the importance of supports that both listen to and guide these women throughout their pregnancy and parenthood.